Unsiloed podcast is produced by University FM, elevating the stories of your institution.
Welcome to Unsiloed. This is Greg LeBlanc, and I'm here today with Vivian Lee, who is a fellow at Harvard Business School, also lectures at Harvard Medical School, used to be with Verily, which is Google's healthcare initiative, and also ran a bunch of different medical institutes, right? Most famous, I guess, in Utah, and also the author of this book called The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone. Welcome, Vivian.
Thanks so much. Great to be with you.
Now, look, healthcare is probably one of the most messed up parts of the American economy. I mean, you point out in the book that almost all of the wage gains that a typical worker would have received over the last couple decades has been soaked up by increased medical expenditures, right? And when we compare how much we spend on healthcare here in the U.S. with other countries, and we compare it to the health outcomes, it seems like, we're really not getting a very good deal here in America. And it's kind of a mystery. And a lot of the people that I've talked to on this podcast have said, well, that's capitalism. And I don't really like this explanation because, capitalism for some people is kind of why, we only have to work for 5 minutes to get, a day's worth of light. Whereas, 100 years ago, you had to work all day to get a little bit of light, right? 100 years ago, you had to work 8 hours to feed yourself. Now you can work 15 minutes to feed yourself. And so the story of capitalism for some people is all about increasing productivity, right? And healthcare seems to be exempt from this trend. It seems to be going in the opposite direction, where it becomes kind of less productive from year to year. So your book, Long Fix, tries to explain this and also to offer up some actionable remedies. So, what is the core problem with the American healthcare economy?
It's hard to distill over $1 trillion, very complicated industry into one or two sound bites. But I think there are a few different pieces that are probably the most important. So when you talk about capitalism, there are these, I'm not an economist, but I'll say that there are these underlying expectations for capitalism to really work effectively. And most of those expectations don't really apply that well in healthcare. So, for example, to begin with, your consumer of the services or goods are not the people usually who are directly paying for them. You have your third-party insurers, or you have Medicare, Medicaid. You have a huge amount of information asymmetry, so the people who are purchasing those goods and services really generally don't understand as much about them as we might if we just go and buy, a pair of jeans or even kick the tires of a car. And in particular, the times when we really need those services, after an accident or, God forbid, some bad disease has afflicted us, we have a heart attack, that's not the moment when we're going to sit there and sort of question the capabilities of the service that's being delivered to us. So those are a couple of key factors. And a third one that is really, I think, uniquely American is the fact that the payment not only isn't direct to consumer, but it's really rolled up through our employers. So we have, as you alluded to, and as we talk about in the book, the fact that a lot of our payment for the healthcare that we get is really taken out of our paychecks, and then our employers represent us. This is true for about half of all Americans. So our employers now represent us and are supposed to be the people who really look after our interest in this sort of market of healthcare. And again, when you think about information asymmetry, or not even information, it's just, does it really make sense for the leaders of HR benefits for GE or GM or a local store to be responsible for negotiating your health care? Doesn't really make sense. So the market, sort of in a capitalistic kind of sense, isn't really working particularly efficiently or effectively. And then we have one other factor, which is that that differentiates us, because we're not the only country that has some private health care and some public care. You know, not every system has a fully public system, but even in those that have a mixed model like we do, the one other factor that I think really differentiates us, which I hope we will continue to address, is that we don't have basic universal health care for everybody. Not bells and whistles fancy, but just basic health care for everyone. And so part of the Affordable Care Act was trying to get us there so that everyone could have kind of a basic level of health care. And that is now available for a lot of people, but we still have, 9% or so, 8 or 9% of the American population that is uninsured. And what that means is that, in healthcare, we are responsible for caring for people when they show up to us. And we can't decline people, just because they don't have health insurance. So as a result, we also have this strange subsidization model within healthcare where we have to overcharge some people in order to cover the costs of care for those who aren't covered. So all of these factors, and of course there are many other components to it, but I'd say those are probably some of the biggest issues. If you want to think about capitalism and the force of capitalism, instead we've got some things sort of turned around, so that what I call in the book the $1 trillion tug of war every year between the payers and the providers has us, as people, patients, members, consumers, whatever you call it, so we're sort of in the middle. And so instead of our healthcare getting better with capitalism and all the market forces, it's actually making it worse.
Yeah, it feels like for the last couple decades, the debate over healthcare has focused on kind of who pays, right? So universal healthcare versus individual responsibility and so forth. But it seems like the who pays question is independent of, how much we pay, right? I mean, the real problem seems to me to be the sheer cost of the system relative to what we get. And I think at the beginning of the book, you highlight that one of the key problems is this kind of pay for action model, right? This fee for service model. And it does seem a little odd, right? We don't see this in other industries. I mean, we do to some degree. I guess, in journalism, they pay by the word, right? But if you get particularly wordy, then they kind of fire you, right? So we don't generally see that where you pay for input. Productivity is about maximizing output per input, not maximizing input, right? So where did this whole fee for service business model come from? I mean, I guess in law firms we sometimes see that also, like with billable hours, right? But where did that come from, and why is it so persistent?
That's a really great question. When healthcare first started, I think nobody expected the growth. When we first started after World War II with this idea of employers offering it kind of as a perk, nobody expected that they were going to end up spending such a huge chunk of their budgets on healthcare. And then the same thing is true when the government started paying for healthcare through Medicare. And in the beginning, it made sense. You're delivering a baby, you get paid a certain amount of money for delivering the baby. You take care of it. It's like dentistry. It's like other services today still. Plumbing. Lots of kind of these services are paid in that fee-for-service way. But I think people, a combination of the sort of gradual growth of healthcare utilization and gradual increase in our own capabilities in healthcare. So when I started in healthcare, we had CAT scans. We didn't really have MRI machines, and we certainly didn't have proton beam therapies. We didn't have a lot of the really, really expensive technologies. And so a lot of what we experienced in the early days, at a low level, our society could manage it. At a higher and higher level, as we go to personalized medicine with individual gene therapies that are a couple of $1 million each, it really becomes an unscalable factor. So I'd say that's one component. And the other component is back to this issue of information asymmetry, where I think it's been difficult for those who are paying to really get their heads around and really understand the ways in which they can measure outcomes. what is the right measure of an outcome, and what's the right way of balancing individual responsibility, because we're a society that really believes in individual, holding people accountable for their own actions, and there is a huge part of that in healthcare. So how do we find that right balance? It's been difficult. So I'll give you one quick example. So in the last maybe 20 years or so, employers have tried to get on top of this. And one of the ways in which they've approached it is to put more and more responsibility on the employee. So you will notice, probably yourself, that, and most of your listeners will notice that you have more out-of-pocket payments. You have higher deductibles. You have higher co-pays now. Every time you go in, there is something you have to co-pay, whereas in the past, a lot of us didn't have to do that. And so now, actually, these days, the average employee is covering about 30% of their healthcare costs out of pocket. So it's not really a full free ride when you're employed anymore. It used to be, but it's not anymore. And the thinking was, well, if you have more skin in the game, that's just sort of the whole skin in the game theory, that people would behave more responsibly. They'd exercise more, they'd eat better, they'd drive more safely, But in fact, there have been some amazingly good studies. Rand Corporation did a fantastic study maybe 20 years ago, basically debunking this basic idea. It's sort of the takeaway from their research is that most people, when they have a significant out-of-pocket skin in the game, they just reduce their utilization. They don't differentiate between, I shouldn't go to the emergency room when just going to my primary care doc would be good enough for my strep throat test. They don't differentiate that versus, I should just skip these vaccinations, or I should just skip my colonoscopy. They just reduce utilization. And when you reduce some utilization, like you don't get your colonoscopy and you miss a colon cancer, and then 5 years later you show up with a god-awful cancer that now needs a lot of treatment, and it's awful for you, and it's awful for everything. It's obviously it's not a system that really works. And yet, that's been the effort for the last, I would say, that was about a 10, 15-year effort. And I think now employers have kind of run the limit of that. I mean, there's only so much we can pay out of pocket, and are realizing, well, actually, that isn't really holding costs back. So that's an example of how the people who are paying for it have such a large gap in their ability to control it and their ability to, really develop better models. So I think that those have been some problems. There have been some brighter. Yeah, go ahead.
I mean, is there a presumption that healthcare providers are not economic actors, right? That they don't respond to incentives? That a doctor will decide that a procedure is necessary or not necessary, completely independent of the revenue implications? I mean, is that sort of why we might think this is a sensible way to kind of structure the revenue of healthcare providers?
Well, there's a combination of factors there. I think that most providers, most clinicians, I feel, really are trained to practice medicine and to care for their patients, whether it's doctors, nurses, pharmacists. There are always bad actors who try to take advantage of situations. But fundamentally, people are trying to do good. There are a few factors that weigh into the increased utilization of healthcare and increased costs of healthcare. Some of which is definitely has to do with the financial incentives of the health systems. Some of it has to do with concerns about medical malpractice, about litigation. And there's also the whole idea of supply-driven demand, that as you build these facilities, as you build these resources, you have more capacity. So in the UK, you might need to wait 6 months for that hip operation. Or you might have to wait 3 months for your MRI scan before you can get on the schedule for a potential hip operation. And here, you can hop in tomorrow. Especially you can hop in tomorrow with your back pain. So this is, a very common issue. Maybe this would be the best example to take a listener through. So many of us have back pain. It's very common, affects maybe a quarter of all adult Americans. It's just so common to have back pain. And if you look at the literature, for most people, the back pain goes away after a few weeks, a few months. For most people. Of course, for some people it doesn't. But for most people it does. And then sometimes you need some physical therapy, and that also helps. So if you let this condition take its natural course, or if you just follow the medical guidelines, you'd have significantly less consumption of health care. But what happens? You've got bad back pain. There's a tiny, tiny chance that there's something really severe and significant. Very, very small chance. But there is one. It's not negligible. You go into your doctor's office. You want your doctor to do something about it. I've got this pain. You're not going to just send me home and tell me to exercise, right? And so those desires they're all confluent, because you've got an empty MRI scanner here. Every time I pop you in, the system makes another $1,000 or whatever. They make some money off of that. You want me to do something, and I'm a doctor, and I'm supposed to do something to help you. And so then you get into the MRI scanner, and the vast majority of adults have some abnormalities in their spine, a lot of wear and tear. This disc isn't sitting out quite right. There's a little wear to it, and so I might see something on that scanner. There have been some great papers that have shown that a lot of times what I see on the MRI scan doesn't really have much to do with your symptoms, but I do see them. So now we see something. There's an abnormality on your spine. You still want me to do something. I say, well, I don't know. Send me to an orthopedic surgeon. Orthopedic surgeon says, well, that could be causing your pain. I'm not sure. Don't know. We could operate on you. Next thing you know, now you've had an operation. When in fact, vast majority of people, if we just let you be for 6 to 12 weeks, you would have been fine. So that's a kind of a typical, I think that's an example of how a fee-for-service model, patients who are not particularly patient, we're not a very patient society, and we want the best of care for everybody, which is understandable. And so these things all converge, and then you have systems who are going to profit from it when it's done.
Now, an alternative model would be to sort of pay for results, right? So you talk about these models where a healthcare provider is effectively compensated a flat fee, right? As long as the patient is, alive and healthy, they get the flat fee, and then they have to absorb all of the expenses associated with keeping that patient healthy. But I mean, that creates kind of perverse incentives of its own, right? First of all, you want to avoid the sickest possible people and just focus on the healthy people, right? And so trying to choose the right customer becomes a big part of the game. But it also, it doesn't account for intertemporal trade-offs if that provider is not expected to hold on to that patient for an infinite amount of time, right? So if you know that they're going to be moving on to a different provider, 3 years from now, then it doesn't really make any sense to invest in preventative care, right? So, I mean, it seems like no matter what system you pick, there's going to be some difficult incentive problems.
Well, you're making a good point in a couple of different ways. I'd say, first of all, yes, you're right. Anytime we want to change the system, it's going to be hard. It is hard because there's already so many dollars in healthcare, and there's so many vested interests who naturally, if they're doing well, they want to maintain the status quo. So change is hard, especially I'd say in healthcare because of how much money is already involved. But I actually would say no, that some of your concerns about this idea of fixed payment or paying for outcomes can be addressed. So for example, this concern about avoiding patients who are the sickest. That would be completely true if the payer paid a fixed amount for everybody and the amount was the same. But with data, with actuarial modeling, we could have a reasonable sense of what would be a fair amount of payment for, let's say, a person who has multiple conditions versus somebody who is essentially healthy and unlikely to have anything significant in the coming year. So that's already happening. There's already the ability to do that kind of what we call risk adjustment, but some way of adjusting for that. And I think the other thing that you mentioned about the intertemporal trade-offs, that is such a good point. So I think that would explain why some of the earliest efforts at really trying to think about paying in a new way have come out of Medicare. Because once you're in Medicare, once you hit 65, you're in Medicare typically for a while. We hope you're in Medicare for a while. And so in the Medicare program, Medicare Advantage was proposed early on. One flavor of Medicare Advantage pays the provider a fixed amount of money each year for keeping the patient well. And there are some pretty clear and strict criteria for that. And what we've seen out of these Medicare Advantage programs, many of them have been very innovative in the ways in which they've used those dollars, because what you're saying is, instead of billing Medicare every time you do something to the patient, we're just going to give you this fixed amount, and you could think about how to use those dollars. And it really gives a lot of these groups a fair amount of autonomy. And so some of them have done some very interesting things, like really one of the earliest programs that I was studying offered regular visits for patients who were rather frail, often frail elderly patients, and just said, we're just going to see you once a month no matter what, because we know that it's good to keep an eye on you. They would offer free transportation, shuttles to and from clinic, so that transportation wasn't an issue. There were sort of social nights at the clinic, game nights, for example, because loneliness is such an issue, and then they had fall prevention courses to help people prevent falls. And all of these programs really came to light during the COVID pandemic. So in the COVID pandemic, when everyone else was operating fee-for-service and essentially had to shut down because they weren't collecting fees, the Medicare Advantage practices had this huge advantage. As they put it, they were like subscription models. You'd already subscribed for the year. You were already there. So they could use the dollars that were already coming in from Medicare and modify their clinics, deliver medications to their patients' homes. They could respond to the pandemic in a really proactive way, and actually demonstrated some significantly better outcomes. So I think this idea of paying for outcomes is a good one. It's a valid one. I think, in my view, it's one of the key steps to moving our own healthcare system forward. The tricky part is, as you described, extending this to the more employer-based payment part of the population, the other half of Americans, because there, as you mentioned, we typically, I think the average duration with an employer may be around 4 years, and in some industries it's 1 or 2 years, and so it's just not long enough to make those investments. I do think there is an opportunity for all the dollars that people are putting in, all the dollars that employers are putting in. There is could be a scheme where you just pool those dollars. You can create some model where it acts effectively like Medicare does for seniors, but it potentially comes from the private sector through a pooled model. And if you have confidence that this model can lower the cost of care, it would be beneficial to everybody, all of the employers who would put into this pool. So I think there are ways around that, but we haven't yet really explored that in this country.
Now, in every chapter of the book, you end with things that different folks can do, right? Things that patients can do and things that clinicians can do. And you also mention how you can impact outcomes through participating in the political process. But it seems like most Americans are completely oblivious to how much they are spending on healthcare, right? I mean, they're aware of their out-of-pocket costs. And so in cases where, they have these big deductibles or, percentages, co-pays, they're aware of that. But they're not aware because the employer is paying a big chunk of it, and because the government's paying a big chunk of it. Sometimes you'll see the bill. I mean, I recently got a concussion and I got a $80,000 bill, right? And I was like, well, what the heck? I mean, I didn't have to pay any of it, but I was amazed at $80,000 for an X-ray. I mean, this is nuts. So, I mean, do we need to make Americans more aware of how much is being spent on their behalf, which presumably would otherwise go into their pocketbooks if we could somehow constrain this expenditure?
I feel like it's very important because of the way in which healthcare is managed in this country. I think it's very important that everyone really understand a little bit about healthcare and where their dollars are going. When you look at the graphs, as you started this conversation by pointing out, all of us would be doing a lot better if our healthcare expenditures were lower. It's just hidden from us because it's taken out before we even get our paychecks, because our employers are using those dollars that should have been going to our pay raises for the last 20, 25 years and using it instead to pay for healthcare costs. I think we need to know it for a number of reasons. One, because we need the public to move forward to be able to improve healthcare payment policies in this country. We have to act through the way in which we vote. We also need it because we need to understand better, I think, our own actions. What of our behaviors are the most important for our own health outcomes? And so having a more nuanced understanding of what we can do in terms of our daily behaviors that can impact our own health outcomes, I think would be also really, really important. So both from a policy perspective and from a personal perspective, I think it's really important. As long as we have this pretty capitalistic approach to healthcare, then we have to be better informed consumers about how we can for our own health, and then also how we consume healthcare as customers in this market.
Well, I mean, if the employers are footing most of the bill, then one would think that they would be taking a greater interest in keeping costs down. I forget who it was you quoted who said that General Motors was a healthcare provider with a auto manufacturing plant attached or something like that, right? And I do work with pension funds, and the pension funds, I mean, these public employee unions and pension funds, I mean, the amount of healthcare spend that they're responsible for is astronomical. So, why aren't the employers taking a greater interest? You highlight how a typical CEO just pushes this off to the HR department, says, here, cover this, right? But they don't see it as something which could presumably be controlled the way other costs are controlled. Is it because they don't think they have any power over these expenditures?
Well, there have been efforts, and there are efforts. There are these large organizations that are business groups on health that all come together to try to with organizations that help to represent them and represent their interests. So there have been efforts, probably not as much success as we would hope, given the trends and given the direction. I think that the other piece to understand is and actually I've written a few papers, and others have written even better papers, I'm sure, about this topic, because I think there's a real opportunity for the healthcare businesses to actually learn from many of these community business leaders. So one of the recommendations, for example, in the chapter that talks about this piece is that I really recommend that CEOs or leaders of businesses get involved with their community healthcare systems. They all have boards, community boards, or fiduciary boards, depending on the nature of the healthcare system. Serve on those boards, understand a little bit more about the healthcare business. And also, there are many ways in which those businesses can offer their expertise. So, for example, you may ask us, why in healthcare are these costs going up? Are there ways in which we can reduce our healthcare expenditures through improved operations within our own health systems? And I would say absolutely. So the effort, for example, to deploy lean manufacturing through every other industry has really only modestly affected healthcare. We have a very high rate of medical mistakes. Safety is a huge issue in American healthcare. There was just a paper that came out maybe about a year or so ago that showed us that we had made a lot of improvements since 2000, and after COVID, we're back to where we were in 2000. So about 1 in 3 Americans who come out of a healthcare event have had have experienced some kind of medical mistake. It's not always harmful. Maybe the dose of your medication wasn't quite, at the right time, and so it's not always harmful, but a lot of medical mistakes. So there's a lot of things that we could do to improve. One of the areas that I talk a lot about in the book, in one section of the book, is about the need for healthcare providers to really understand their costs of care, what it costs us to run our businesses. And I challenge all of our listeners, the next time you see a provider, if you go in, for example, if you have a concussion, ask the the person doing the MRI or the CAT scan on you. What does it cost you to do this scan on me? Not how much are you going to bill me, but what does it actually cost you to run your business? And see how many of them actually know the answer to that. And I'm gonna say that when we first did this work, maybe 10 years ago, the answer would have been 0. Maybe now there's a few percentage of people who actually do know the data, but very, very low. And so then you ask yourself, well, is it any wonder that our costs are out of control if the suppliers of the service, like the doctors or the nurses, really have no idea about the costs? So there are a lot of inherent inefficiencies in the way in which we deliver healthcare. The third big bucket is administrative overhead. We spend 20%, I mean, huge percent of our healthcare costs are going to administrative overhead, paperwork, all of those statements that you get that say this is not a bill, and you wonder, well, what is this exactly? There's a lot of wasted dollars going in there. And all of these areas, I feel like these other industries could really help us in healthcare get a lot better, a lot faster.
Yeah, that chapter really kind of astonished me. I mean, given that there are so many healthcare providers that are for-profit entities, one would think that they would be acutely conscious of the costs that they incur from all of the different procedures. I mean, how do you explain that? I mean, we've seen plenty of, MBAs moving into administrative roles. I've taught plenty of MDs in my MBA classes. Why are basic things like cost accounting ignored in this sector? It seems kind of crazy.
Well, I don't want to mislead your listeners or you. Cost accounting is common across all of healthcare. It's cost accounting, though, that is rolled up to the CFO level. It's rolled up cost accounting. So if you go into any hospital, I mean, for decades now, of course, we could tell you what we're spending on supplies and labor and the usual cost accounting. The cost accounting I'm speaking about is attributable to the individual provider. So yes, the C-suite, if you ask every CFO, oh, I've got cost accounting, I've had that for decades. But then if you go and ask any doctor or a nurse practitioner about their actual cost, that's where we've really had no insight. And there's a couple of reasons why. First of all, in medical training, we're taught that first and foremost, we care about your health and your health outcomes. We should not be looking at if this medication is expensive or if we should really be first and foremost thinking about your health. That's really how we're trained in medicine. And I think that's admirable. Having said that, I don't think that means that we shouldn't look at the costs. For example, if you have a meal catered, first and foremost, the caterer wants to give you a really good meal. But you don't really want your caterer walking around a grocery store with no price tags. You kind of want to have some constraints around that, right? Some insight into what that's going to be. So I think that's the first disconnect. The second disconnect is that in many health systems, the physicians are often employed they're often contracted in to work in the hospital as opposed to being directly employed by the hospital. And there is, even if they're employed by the hospital, there's a shortage of many of the specialist physicians in the country. At least there's a perceived shortage given how much healthcare we utilize. If we use less healthcare, there's a debate about whether we really are falling short of doctors, or is it just we're using doctors too much unnecessarily. But right now there is a shortage of physicians in most places. And so many of the hospital leaders and hospital administrators are cautious about challenging the ways in which physicians practice medicine. So one of the ways that we really were able to work through this when I was at the University of Utah was, first of all, we got the data. We took our cost accounting information and then we attributed down to each clinician. We were mindful of the fact that your data are never perfect, so we allowed physicians and clinicians to push back and say, well, you don't have this quite attributed correctly. I don't know why I'm taken responsible for this service. That shouldn't be layered into my cost accounting. So we did a little bit of adjustment. And then we just shared the data and allowed the clinicians to compare each other. So for example, if you look at all the orthopedic surgeons who were doing hip replacements, we saw a pretty significant difference in the costs, what it cost us to do that hip operation from surgeon to surgeon, even though their outcomes were the same and the underlying healthiness of the patients were pretty similar. So then so they would actually start to ask each other, well, I wonder why my costs are so much higher than my friend next door, my colleague next door. And it would turn out to be that artificial hip that they were using, they had trained in different places. Healthcare is an apprenticeship, so you learn wherever you train and you kind of bring those with you. So they trained in different places. They'd come to Utah and they were using artificial hips from different vendors. And there was a threefold difference in cost in those artificial hips. Well, since we never looked at the cost, we never really knew that, we meaning the surgeons. Once they saw that, they became consumers. They were kind of almost representing the patient at that point. They said, well, this is ridiculous. Why am I paying 3 times? Why are we paying, the collective paying 3 times more for this hip when it's not doing any better? So they did a few things. They went back and talked to the suppliers. They talked to the people that they knew and said, you're not making me look very good. Why is the hip that I've chosen to work on, because I thought your product was the best, threefold more expensive? Justify that for me. And if they weren't able to secure any kind of discounts or anything directly, we would work to moving to a less expensive model. But it was very much physician-led and physician-driven. It wasn't particularly top-down. But what it did do is it really significantly reduced our costs. And as a healthcare system, by reducing those costs of care, those were really very beneficial for us as a business. So that's an example of, I think, what could be done and why I feel like there's still a lot of opportunity across health systems to really try to get our costs down.
Well, do doctors inherently resist standardization? Do they is there sort of the cult of the medical professional and their expertise? One of the metaphors that you use in the book, which I really liked, is this idea. I guess some people would be horrified, but the idea that, the manufacturing model, right? You have a sick patient is the raw material and the healthy patient is the finished product. And, we want to get them through as quickly and as efficiently as possible. And so if there are best practices, we'd want those best practices to diffuse and, proliferate. But, we give medical professionals an awful lot of discretion. We don't kind of give them very strict guidelines, right? Whereas if you're working on the assembly line, right, you don't really have a choice of which, nut and bolt to use, right? You got to use the bolt that has been determined to be the best one for the product. Is that a problem in healthcare? The cult of the heroic individual doctor. Do they resist standardization? Right? Is there a culture of resistance to algorithmic practice?
This is a really great question, because I feel like when you're thinking about working with professionals who really pride themselves in being professionals with expert knowledge. Let's just take your typical, orthopedic surgeon or neurosurgeon, somebody who's operating every day, since that's the closest to the metaphor of a assembly line kind of mindset potentially. When you're talking about people who are functioning at that level, every step of the operation, they are making decisions. They are making judgment calls about what to do. Do I clamp off that artery? Do I twist this? Do I, how do I actually do this procedure? So there's naturally in a workforce that is operating at that level, that has undergone, since college, 15 years of additional training, there's naturally a desire to be able to kind of feel like you have autonomy and to have a sense of pride over the mastery over your work. I'm alluding to some of the words that Daniel Pink uses in his book Drive about intrinsic motivation, for example. And I'd say that these professionals are very intrinsically motivated. And so, on the other hand, what we also have in the mindset of these professionals is a very strong push towards evidence-based medicine. So we very much respect that the way in which we practice should be based on data. should be driven by evidence. And when I say evidence, what I mean is that the reason why we use this antibiotic and not that antibiotic, and why we use an antibiotic at all before you undergo an operation, is because there's evidence. There's been clinical trials that have shown that we must do things in this way in order to minimize your risk of infection during an operation, for example. So that would be evidence-based medicine. And all of us are very much trained to think that way, to think that, well, we need data, we need evidence to justify the way in which we practice. What's tricky in healthcare is that the amount of evidence that's generated isn't keeping up with the pace of change and new products and new opportunities that are in the market. And it doesn't keep up with the fact that people are people. Every patient is not the same. No two patients are identical no matter what. And so you aren't exactly in an assembly line, because not every widget or no patient would want to think of themselves as a widget, let's put it that way. And so you have this tension between how can I practice in a way that's really evidence-based and standardize everything that is justifiably standardizable, versus my own autonomy to make judgments about things that I think are better. And I think where we're at a really tipping point now, and this is part of the reason why after writing the long fix, I went and worked at Verily as part of the Alphabet Google family, was that I think that increasingly we have the opportunity to use the data from all the operating rooms that are going on in the country and in the world every single day, where we have information about how surgeons are doing things in particular ways with different kinds of patients. We know about the different patients, we know about what the surgeons are doing, and we also know about the outcomes that happen 6 months, a year later, 2 years later. We've been collecting these data with our digital health systems for a long time now. What we haven't been doing is using the data to create more evidence, to say, oh, actually, we really do know that doing it exactly this way with this artificial hip provides really good outcomes, and that would be the evidence that you would need to talk the surgeon or to convince everybody, to go to that standard approach. And we also have the information about the costs. So not only could we look at better quality, but if quality were equal and costs were less in this scenario versus that scenario, we could even not only push for better outcomes, but actually more cost-effective outcomes. And that's where I think we have an enormous amount of opportunity today to transform healthcare.
Well, maybe the assembly line worker is not the right metaphor. Perhaps the metaphor of a pilot would be better, right? And pilots have intrinsic motivation, and they're passionate about flying and so forth. But when it comes to something like how much fuel do you need for this flight from Indianapolis to St. Louis, we don't leave it up to the pilot, right? We don't require the pilot to evaluate the evidence and look at read the Journal of Flight Fuel Management and see what the latest theory is on that, right? We have software that looks at the distance, that looks at the capacity of the plane, looks at the weight of the passengers and the luggage, and calculates the optimal amount of fuel, and the pilot doesn't need to worry about that, right? So why would a doctor need to know all this stuff, right? Why couldn't that just be provided to them? I mean, when I read I think the New York Times has this feature, or used to have this feature every week, where there would be some doctor with some patient who had some unusual symptoms, and the doctor was puzzling over it. No one could figure it out. And then the doctor is at a cocktail party talking to somebody, and they say, oh, well, did you ask the patient if they'd been to Madagascar? And it's like, no. And then they ask, and it's like, oh, boom. And then they discover it. And I'm like, and this is written up as if this doctor is a hero. And I'm just thinking, this is crazy, right? This is absolutely crazy that there isn't just a systematic series of questions that one could ask and elicit a diagnosis, right? Why would we require this doctor? Your outcome is a function of whether or not this doctor happens to be lucky enough to go to the right cocktail party. I mean, this seems crazy.
I could not agree with you more. And the fact that your podcast has to do with silos or unsiloing, I would say that in the space of medical data, the ability to translate those data into useful, actionable insights that can make everyone's life better is so untapped at this point in time. Let's just call it a huge, huge opportunity. So absolutely. For one set of examples, what you just described would be, let's say, the pilot equivalent. Let's just go back into our operating room example, although obviously this would be true in any other kind of scenario. But in the operating room, now so much of surgery is done laparoscopically. So laparoscopic surgery is where you have, instead of making a big incision in somebody's abdomen, you have these two little holes, and you put these tools through the holes, and you can operate, and then there's a camera also. And so you can take out an appendix without even an incision. You can just sort of do everything through these little holes. As a result, you have cameras recording these operations everywhere, all the time. So you have natural recording of what is happening in the operating room, what's happening in the operating field in the operating room. And so people are starting to, we worked on this a little bit at Verily, for example, and others are also working on this, capturing all the video data and learning from all the experiences of hundreds, if not, potentially, all the surgeons in the world. You could be learning from them and in a way guiding them. So in the moment where let's say the person has an infection and it's just messy in there and you can't quite see am I about to clip something that could be an artery that I shouldn't be clipping? Warning, do not clip that. AI is already identified it, is already giving you instructions. Or, well, in the last 800 cases, this is actually how in the last 800 cases, Dr. Greg, this is sort of how you would have proceeded, but we noticed you're kind of deviating a little bit from how you typically do this operation, which typically leads to a really good outcome. So maybe you should, all of that is possible. All of that's possible, whether it's the visual images on these cameras or whether it's in just our day-to-day practice with patients, recommending them medication adjustments, We have so much information about patient biology now that's also not being tapped into. We know, for example, that, let's say diabetes, everybody who has diabetes, we have different diets, and the way in which, we had a business, or we have a business at Verily called On Duo, which manages people with diabetes. And what you discover is that if you take a room full of people and if you give everybody a bowl of oatmeal, everybody, a Caesar salad, our blood sugars all react differently. None of us have the same response to a similar diet. Very, very personalized. We actually have that information now for our patients. How can we use that kind of information to inform how we prescribe, how we make recommendations about their diets? How can we make it more automated so that it's even just surfacing on an app, or it's just, it's surfacing in real time with the patient? We don't need to be there to be telling them, obviously. And so there are many products that are starting to do that for diabetes. But what about all other conditions? How do we actually use data to learn from people and all of their uniquenesses and all their differences? And similarly, how do we do that for physicians? It's really, really untapped. And we're only just starting to make progress in this field because the data have been so siloed. It's been very, very difficult to access the electronic health record data in a way at scale enough. But that's really been starting to change in the last few years. So I'm optimistic that it will start to get better, and there'll be more APIs and more people can build, more people in Silicon Valley where you are can build these tools and technologies on top of all that data.
Yeah, one thing you talked about also is, a lot of healthcare systems, they don't have a good handle on how much everybody's time is worth, right? And so, doctors are extremely expensive. Nurses are slightly less expensive, and then we have people that are even cheaper in the system. And a normal employer would try to figure out how to push the activities down to the cheapest person who can do it, and thereby freeing up the time of the expensive folks. But we don't seem to do that in healthcare, and so doctors are spending a lot of time doing stuff that don't require 15 years of higher education, right? And then that means that they don't have a whole lot of time to do the things that only they can do. How do we do that better? I mean, and I think in part the de-skilling that you're talking about, if we can use automation and we can use analytics to kind of de-skill things, we could probably compress less education into the people who are participating in this process. Because clearly medical education is extremely expensive. And my guess is that on any given day, a doctor only uses a tiny percentage of the education the expensive education that they've received.
Right. Yeah. I hope that your listeners are getting a sense that while it feels that healthcare has so many things wrong with it, the sea of opportunities is really more like an ocean of opportunities. Almost everywhere you look, there are opportunities for innovation and improvement. So I hope that leaves people with a sense of optimism, because this is another example. This is really.
I get excited when I recognize inefficiencies, because that means it's like, wow, we're not at the constraint. We've got all this room to grow.
Yeah, if you're ever feeling sad or depressed, just come and look at healthcare, because there's just infinite number of opportunities, infinite number of inefficiencies to tackle. So this is one of them. So when we look at, when I talked about the cost accounting piece, so when we started looking at accounting, sort of pushing down the overall centralized cost accounting data into our system at a physician by physician level when I was at the University of Utah. And we do talk a lot about this in the book, because I think this is a really great story. You discover that, of course, like in most businesses, especially service businesses, a significant chunk of those costs are labor. So the costs are really coming around who's doing what work and how much time are they spending doing that. And a related part of that, we actually looked at, for example, the cost of imaging, where you might naturally think, really expensive technology. That's why the MRIs and the CAT scans and the nuclear medicine scans are so expensive, because look at those machines. You never see those at garage sales. That's got to be a big factor. But actually, it turns out for a CAT scan or an MRI scan, labor is about 80% of the cost. So once you realize labor is so expensive, then you start to think to yourself, about 40% of that was the physician, about 40% of that was the tech or the nurse or the people who were supporting the patient during the scan, for example. It immediately makes you think, well, why is that radiologist spending that much time on the phone, calling up various people to try to find last year's scan, because they can't find last year's scan because it was done in some other clinic? Or why are they calling up the referring doctor to say, what is the person's kidney function, because we want to make sure we can give them our CAT scan dye, and their kidney function has to be good. Why are they hunting around for this miscellaneous information that seems to be untrackable at that point?
Well, also the
Why
data
isn't somebody
entry
else doing
piece
that work?
seems like a huge time suck.
Data entry piece, the squabbling with insurers over, we need to have what's called prior authorization. So the patient has a scan ordered, and because the insurers are worried that is overuse, this is just one of their things to try to constrain costs, we end up kind of having to call the insurers and say, well, no, this patient really does need the scan. And so all of that work, that's the administrative burden that I'm talking about, and especially when it's on the shoulders of the more high-cost pieces of labor, then you're really talking about inefficiencies from an economic perspective. There's a really interesting study that they did at Duke University that looked at just the primary care doctors. So not surgeons, primary care doctors in clinics every day. And what they discovered was it cost about $100,000 per year per doctor in just administrative time. Just dealing with, bills or paying for this or trying to find old studies or old medical records, just hunting around, whatever, just $100,000 per doctor per year of mostly administrative waste, which, as you allude to, if you just had a computer system or if you had things that actually worked, should all be automated. None of that needs to really take a human's time.
Well,
so
now when we talk about the cost
is
of
a
healthcare,
huge
we also
opportunity.
we fail to incorporate the costs that the patients incur, right? So, I know folks who've gone to hospitals, they'll have a scan at 9 a.m. and then they'll meet with the doctor at 3 p.m. and then they're sitting there all day in the waiting room. right? And that's a cost, but it doesn't show up in the numbers. Most service businesses realize that they can monetize higher quality service by charging higher fees. Healthcare, that's more difficult to do. So you talked about, in your experience, how you started to think carefully about kind of customer satisfaction. Why is customer satisfaction? I mean, is it the nature of the business model that makes it difficult for you to charge differentially for higher quality customer experience?
It's funny that you asked this question, because this is yet another example of how, when we started, you sort of asked, well, why isn't healthcare just like any other business? And we talked about a few different reasons, but your question about customer service really highlights for me, when I hear you ask it, another example of just how different healthcare really is. Because healthcare, you're coming to me for a service, but I'm not really like your plumber. I'm actually looking after your health and your well-being. And it's really something that that some economists have actually talked about in terms of co-production. It's a service that's not really just produced by me. It's something that we actually have to work on together to be successful. And that could be at the very simple level of just simply you actually expressing your real concerns to me and me understanding what your symptoms are, or some of it could be psychological as well as physical or social. Some of it can be understanding, communicating. Some of it can be, if we talk about you should be taking this medication and you don't take it, well, our co-production isn't really working, So how do we co-produce? And I think a big part of the work that we did around patient satisfaction that started before I arrived at the University of Utah was really started by my predecessor there, Laura Spetz, was really about how we could deliver better outcomes. Because there have been a lot of studies that have shown that you deliver better outcomes when it is really a co-production model, when patients and clinicians are able to make decisions together, when there's shared decision making, as we call it, and when there's kind of a shared responsibility for the outcome. And you can't do that in a system, in a more traditional model, which I would say is very doctor-centric. Healthcare traditionally is doctor-centric. That's why we have people traditionally wait between 9 and 3 before the next study or next scan or whatever. We would never, and of course, if we're the patient, we're furious that that's happening. So, that it's not a patient-centered view, but that's really been evolving a lot. I think we've made a lot of progress in patient centricity in our business. We're not as good as most service industries, but we're a lot better. The Mayo Clinics of the world have set a very high standard for that, for example, I think too, made it just very much a part of their brand. And I think that's actually been very helpful. But I think we don't think about it so much as translating. Yes, of course, I guess from a customer service, 5 yellow stars, like in any other industry, the better you look, the more patients will want to come see you. But in many health systems, especially the large academic systems, are already oversubscribed. So we're not. When I say we, I'm talking about back when I was leading these health systems. We were not so much worried about whether we're getting enough business and whether we're trying to attract the business, and not even necessarily trying to negotiate higher rates with the payers. It's really more about trying to achieve better health outcomes and to create a more patient-centered model of care. And when you do that, it just creates a win-win. It was very satisfying, I will say, that when we did. One of the things that we were able to do when I was in Utah was we significantly improved our patient satisfaction scores by sharing the patient satisfaction data with all of our providers, and then we did a lot of sharing of best practices inside. And then we were the first system to post our scores online. So the 5 yellow stars, next to every doctor's name, so we were the first healthcare system that we know of in the U.S. To do that. And it actually turned out to be very satisfying for our clinicians. I remember talking to one of our urologists and just chatting with him, and he said, yeah, my son called me up this weekend, and he said he'd been surfing the net and he found my website, And he read all the comments that my patients had written about me, and he said, "Dad, you're a pretty good doctor." And it was great, you know. So it can be a very positive force.
I mean, look, we have a lot of unhealthy people in America, right? And it seems like the major determinants of health outcomes occur outside of the healthcare system, right? So, you know, if you smoke a pack of cigarettes a day, I mean, it doesn't really matter whether we spend $1 or $1 million on you, right? I mean, you're not going to live that long, right? I mean, so, you know, as a doctor, there's only so much that you are aware of and only so much that you can control. But your social life and your lifestyle and your diet and your sleep habits and your smoking and drinking habits, I mean, those are the things that are really going to affect your health. Should we be thinking about medicine more broadly? And if so, how would healthcare providers kind of get involved? I mean, would you have to start by sucking in data from different sources? I mean, I like to think that Facebook learns more about me in 5 minutes than my doctor does in a lifetime, right? Because they have access to so much data about me.
Well, you're hitting on a very, very important point, and it's really a broader societal question for us, which is how do we think about people as a whole? Because absolutely, you know, what we talk about in healthcare, as you know, as the social determinants of health are far more important in determining health outcomes than what we do in the clinics and in the hospital and in the operating rooms. Of course, for an individual, maybe what we do in an operating room is very, very important for that person, but across a whole population, so sort of if we just look at a very macro level, it's really what happens in people's homes. It's their own behaviors, it's their own social circumstances. These days, it's the environment that they're exposed to also, and which is going to, I think, increasingly become more and more important in terms of health outcomes, what's happening with our environment. So healthcare needs to be a part of that discussion, but cannot bear the full responsibility for that. In some places, for example, at the University of Utah, we worked on supporting some housing. It's really not a great idea to have hospitals building housing. It's not our area of expertise, and as you can imagine, there's a premium, you know, as soon as somebody's working for a hospital, there's a premium on that. So we need to be able to work across the community and across other both public and private sector efforts and really, really work together. One of the areas that I'm personally very focused on now are the ways in which our healthcare systems can respond to climate change and environmental changes. And not only respond to, but also proactively reduce our own carbon footprint and decarbonize. Healthcare has a very, very high carbon footprint, as you might imagine. And so I think that some of these changes, some of these urgent issues that come up, whether they're heat waves or floods or hurricanes, they really amplify the kind of situations that you're talking about. People who are already housing insecure or have transportation issues or who are already having substance use disorders, you know, this just makes things that much worse. And so it's often in moments of crises that we as a society band together a little bit better and can work together and find new ways of working together. And I think this is going to be, in the next decade or two, has to be a really priority for us. So our health systems themselves have to be strong enough and resilient enough to stand on their own, but also need to play a pretty vital role more broadly in terms of how we can support people in their times of need in ways outside of our clinics. And so I think that's going to be something really important that we have to think a lot about and work on.
Well, I think last question, you know, a lot of people think that the American healthcare system is best of class in the world. There are others that disagree, right? But when we look around the world and we see these different systems that in many cases are more effective on a dollar-for-dollar basis, are there things that we can learn? I mean, should we be spending more time studying other types of systems and try to, you know, model our system after what they do, say, in France or in in the UK or Canada or Singapore?
Well, of course, I always believe that you should learn from other people if you have the opportunity to. And there's no need to try to expect to invent everything perfectly. So we all learn from each other, and that's always been true in the history of time. And I guess I would say that in some respects, for some people, we are best in class here. I think that that's why so many people from around the world will fly to some of our eminent institutions here in the U.S. if they can afford to do that. The challenge for us is not that we don't have best in class. So I don't want to give anybody the impression that we don't have some of the most amazing clinical care, scientific research, and translation of that research into care of anywhere in the world. I would say that we do. The issue is that it's really more of a bimodal. It's not evenly distributed. And so while we have the best of the best, our worst of the worst is significantly people who don't have access to care, and their health outcomes are significantly worse than most other OECD nations, other developed economies. So that's really, I'd say, one of the biggest problems. And in terms of things that we can learn from other countries, there are many things that we can learn. We can learn how to, for example, negotiate for drugs and medical devices based on their ability to contribute to better health outcomes. The UK, Canada,
like cost effectiveness,
a number of other
right?
countries. Cost effectiveness of our pharmaceuticals and medical devices, I'd say. So in the last year, as you know, there's been a law was passed that now starts to enable Medicare to potentially negotiate drug prices, but still it was actually written into the law that that the NIH is actually not allowed to fund research that has to do with the cost effectiveness of medical medications, which is, really, I think that's completely unacceptable. So that's one thing we could definitely learn. Let's price drugs and medical devices based on how much better they are for you. And just because you're a cancer drug doesn't mean you automatically can charge $12,000 a year, even if you don't do much better than any other drug. That needs to change. The ability, like in France or in other countries, to have all of your medical records in one place, potentially on a card, on a chip that's in your back pocket. So anywhere you go, it just travels with you. You own it, but everyone can access it and can follow who you are and what's happening to you. I think that would be an enormous advance. The ability to think in Singapore, they're working so much on how do we think about healthy aging? How do we all age in a healthy way? It's the one thing that's inevitable, hopefully. We hope it's inevitable. We all want to be able to age, and we all want to age in a really healthy way. We have a lot that we could learn from the experiences that they're having there. So there are many things we can learn from other countries, and I think we have a lot of people here who are studying them, but whether they're getting incorporated into our policies yet, I think that's still an opportunity for us.
Well, Vivian, thanks so much for joining me. The book is called The Long Fix, and it really is a hopeful book, an optimistic book. And I think if you read it, you get a sense that there's a huge world of opportunity in healthcare. And I hope more and more people who with backgrounds in business, backgrounds in accounting, backgrounds in systems and operations, think about moving into this sector and seeing what they can do to make things better for all of us. So thanks so much, Vivian.
Thanks so much, Greg.
Unsiloed podcast is produced by University FM, elevating the stories of your institution.